hidden first signs of leukemia that doctors often miss in primary care. Welcome to the official GlobalRPh YouTube channel. If you haven't already, hit that subscribe button to stay updated with our latest videos. Introduction. Leukemia makes up about 3.2% of new cancer cases in the US, but its early symptoms, like fatigue, fever, and easy bruising, often mimic common illnesses, delaying diagnosis. Acute lymphocytic leukemia (ALL) affects children, while acute myelogenous leukemia (AML) is most common in adults. Many cases are found incidentally through blood tests, especially in older adults with comorbidities. This review highlights key early signs and common diagnostic pitfalls in primary care. Subtle hematological changes. First signs of leukemia. The small changes in complete blood count (CBC) often constitute the earliest detectable signs of leukemia, frequently preceding obvious clinical symptoms by months or even years. However, these early hematological shifts can be remarkably deceptive, leading to delayed diagnosis as primary care physicians attribute them to more common conditions. Blood count abnormalities often attributed to other conditions. Early leukemia often presents with subtle but persistent abnormalities on the complete blood count, CBC, which are frequently misattributed to benign conditions. Anemia may be mistaken for iron deficiency or chronic disease. Thrombocytopenia may be linked to medication effects, and leukopenia may be dismissed as a viral response. Copper deficiency can also mimic myelodysplastic syndromes, while autoimmune cytopenias such as immune thrombocytopenia or hemolytic anemia may, in some cases, particularly in 4 to 10% of chronic lymphocytic leukemia (CLL) patients, indicate an underlying malignancy. Persistent or unexplained cytopenias warrant further hematologic evaluation. Persistent mild cytopenias as warning signals. Mild but persistent reductions in blood cell counts, such as pancytopenia, isolated neutropenia, prolonged thrombocytopenia, or anemia unresponsive to iron, can be early warning signs of serious conditions, including leukemia. A study found nearly 1/3 of children with persistent cytopenias had inherited disorders, and most had a genetic predisposition to leukemia. Physicians should consider genetic evaluation when cytopenias remain unexplained. The significance of trending CBC values over time. Monitoring CBC trends over time is more valuable than relying on single results. Gradual declines within normal limits and subtle morphological changes can signal early leukemia. Tracking patterns and progression offers greater diagnostic insight. Primary care providers should establish baseline labs and closely monitor changes, especially if patients present with ongoing fatigue or recurrent infections. Systemic symptoms frequently misattributed. Beyond laboratory values, systemic manifestations often represent early leukemia warning signs that primary care physicians frequently misinterpret. Systemic symptoms appear because of both the direct effects of leukemic cells and the body's response to malignancy, yet they commonly receive alternative explanations. Fatigue dismissed as stress or depression. Fatigue is a nearly universal early symptom of leukemia, but unlike ordinary tiredness, it is persistent, profound, and unrelieved by rest. Often mistaken for stress, depression, or burnout, leukemic fatigue worsens over time and disrupts daily life. It primarily results from anemia due to bone marrow infiltration and impaired red blood cell production. Recurrent infections mistaken for immune deficiency. Up to 20% of patients experience frequent or severe infections before a leukemia diagnosis, typically due to impaired or insufficient white blood cell production. Clinically, this may present as persistent or unusually severe infections, commonly respiratory or urinary, poor or delayed response to antimicrobial therapy, and recurrent infections at the same site or involving the same pathogens. These patterns are often misattributed to viral illnesses such as Epstein-Barr virus or influenza, primary or secondary immunodeficiencies, or stress-related immune suppression. In previously healthy individuals, such atypical infection patterns should prompt a complete blood count and evaluation of immune cell counts to investigate for possible hematologic malignancy. Unexplained weight loss attributed to lifestyle changes. Rapid, unintentional weight loss without changes in diet or activity level can signal an underlying malignancy, including leukemia. This weight loss may result from the metabolic demands of the disease or systemic inflammation. Clinically, it often involves a loss of more than 5% of body weight over 6 to 12 months, despite stable or increased appetite, and may be accompanied by symptoms such as fatigue or fever. However, it is frequently misattributed to lifestyle changes, stress, or minor gastrointestinal or metabolic issues. Unexplained weight loss, particularly when paired with other constitutional symptoms, should prompt further evaluation for possible hematologic malignancy. Night sweats confused with menopause or environmental factors. Approximately 1/3 of leukemia patients report drenching night sweats prior to diagnosis, typically driven by cytokine release and systemic inflammation. These episodes often involve profuse sweating that soaks clothing and bedding, occur in cool environments unrelated to external temperature or bedding materials, and may happen without an accompanying fever. Though low-grade fevers can be present, such symptoms are frequently misattributed to menopause, environmental heat, or anxiety. When night sweats are accompanied by fatigue, weight loss, or lymphadenopathy, clinicians should maintain a high index of suspicion for hematologic malignancies and initiate appropriate diagnostic evaluation. Physical manifestations overlooked in routine examinations. Physical examination findings play a vital role in identifying leukemia, yet certain manifestations often remain unnoticed or misinterpreted during routine assessments. Primary care providers must develop a heightened awareness of these subtle physical signs to facilitate earlier diagnosis. Subtle lymphadenopathy, when to be concerned. Lymphadenopathy is a common yet frequently overlooked sign of leukemia, especially in lymphoid subtypes. It may go unnoticed during routine examinations when lymph nodes are small, painless, or located in less accessible regions. Worrisome features include firm, non-tender nodes that persist or enlarge, involvement of atypical areas such as the supraclavicular, axillary, or posterior cervical regions, progressive enlargement without signs of infection, and generalized lymphadenopathy involving multiple non-contiguous areas. Imaging, particularly in cases of acute lymphoblastic leukemia, ALL, or chronic lymphocytic leukemia, CLL, may reveal mediastinal lymphadenopathy, while a high standardized uptake value, SUV on PET scan, may suggest aggressive disease. Definitive diagnosis requires histopathologic confirmation through biopsy. Petechiae and easy bruising, distinguishing pathological from normal. Leukemia commonly presents with bleeding manifestations due to thrombocytopenia or platelet dysfunction, occurring in up to 24% of patients before diagnosis. Pathologic bruising may appear in unusual locations, such as the back, buttocks, or upper arms, and often occurs without identifiable trauma. Petechiae, non-blanching, pinpoint red spots, are frequently observed on the lower legs, abdomen, or mucous membranes. Other associated signs include concurrent bleeding, example, gingival bleeding or epistaxis, and bruises that take longer than 4 weeks to resolve. These symptoms are often mistaken for effects of minor trauma, coagulation abnormalities, or aging. Persistent or unexplained bruising should prompt a complete blood count and platelet assessment to evaluate for possible hematologic malignancy. Splenomegaly, detection challenges in primary care settings. Splenomegaly can be a subtle yet important finding in leukemia, but it is often missed during routine physical exams due to limited sensitivity, particularly in obese patients or those with a high diaphragm. A spleen tip palpable more than 2 centimeters below the left costal margin is suggestive of enlargement, especially when accompanied by symptoms such as early satiety, abdominal discomfort, or a sense of fullness in the left upper quadrant. However, some healthy individuals, especially those who are thin, may have a naturally palpable spleen, which can complicate interpretation. In uncertain cases, ultrasound is the preferred diagnostic tool given its high sensitivity and absence of radiation exposure. Diagnostic pitfalls in primary care assessment. Early recognition of leukemia in primary care remains difficult due to overlapping symptoms with common conditions and several diagnostic pitfalls. These challenges often lead to delayed referrals. 15% of leukemia patients see their GP 3 or more times before being referred to hospital care. Anchoring bias. When common diagnoses overshadow leukemia, anchoring bias is a major diagnostic barrier where clinicians fixate on an initial diagnosis and overlook new evidence. This can delay critical diagnoses, like mistaking pancytopenia for pneumonia, postponing the recognition of acute myeloid leukemia. A VA study showed heart failure patients were less likely to be tested for pulmonary embolism, despite similar PE rates. Early leukemia symptoms are often misattributed to viral infections, depression, or immune deficiencies. Laboratory interpretation errors in early disease stages. Test interpretation challenges. Even when appropriate labs are ordered, early leukemia can be missed. Factors such as recent transfusions or medications may mask abnormal findings. Interpretation of peripheral smears and other tests is subjective and varies between observers, particularly in identifying and quantifying blasts. Technical errors. Errors in sample handling, such as improper fixation or inconsistencies in flow cytometry gating, can lead to misclassification. False positive results have also been noted, especially with NPM1 marker testing, further complicating the diagnostic process. When to order peripheral blood smears. NICE guidelines recommend urgent blood tests within 48 hours for suspected leukemia, but only 68% of patients receive timely testing. Peripheral smears are crucial when CBCs show unexplained cytopenias, abnormal white counts, or atypical cell morphology. However, their use is limited in primary care due to time constraints and lack of access to expert interpretation. Conclusion: primary care providers are essential in early leukemia detection, but diagnosis is often delayed due to nonspecific symptoms like fatigue or bruising being mistaken for common illnesses. Clinicians should watch for persistent cytopenias, unexplained systemic symptoms, unusual bleeding, and repeated vague complaints. Monitoring lab trends, reassessing initial diagnoses, and minimizing cognitive bias are critical for timely diagnosis and better patient outcomes. Thanks for watching our GlobalRPh production. If you enjoyed the video and found it helpful, don't forget to smash that like button and subscribe to our brand new YouTube channel. We're bringing you a dynamic mix of content across a variety of topics, so there's always something fresh, engaging, and insightful just for you. Your support means the world to us. It helps us grow and keep delivering exciting, high-value content. Stay tuned, because the best is yet to come.